Hi, here I'm Dr. Zal, and the topic is breast cancer. Breast cancer is a malignant tumor that starts in the cells of the breast. A malignant tumor is a group of cancerous cells that can grow into and invade the surrounding tissue or spread, that is, metastasize to the distant areas of the body. The disease occurs almost entirely in women, but men can get it too. Breast cancer is the second leading cause of cancerous death in women. It is important to understand the most breast lumps are benign and not these are the cancerous or malignant we say. The breast has different parts such as lobules are the glands that makes breast milk. So the cancers that start here are called the lobular cancers. Ducts or the small canals that come out from the lobules and carry milk to the nipple. This is the most common place for breast cancer to start, and cancers that start here are called ductal cancers. Nipple is the opening in the skin of the breast come together and turn into a larger ducts so the milk leaves the breast. A less common type of breast cancer called the Paget's disease of the breast can start in the nipple. Fat and connective tissue called the stroma surround the ducts and lobules and helps keep them in place. A less common type of breast cancer, phylloid tumor, can start in the stroma. Blood vessels and lymph vessels are found in each breast. Angiosarcoma, lymphoma, or the less common types can start in the lining of vessels and lymphatics. The presumed cause of breast cancer is DNA damage and estrogen playing a key role. 5 to 10% of breast cancer cases in women are attributed to the BRCA. So, the inherited breast cancer having BRCA1 mutation, that is tumor suppressor gene located on chromosome number 17, and can cause 50 to 65% of breast cancer. And whereas BRCA2, the tumor suppressor gene located on chromosome number 13, can cause 40 to 55% of the breast cancers. However, it is said that 75% of the breast cancers occurs in women with no risk factor. Risk factors for breast cancer are like as family history, that is the first degree relatives such as mother and sister, early menarche, early menopause, late first pregnancy, nulliparity, previous history of breast cancer, lobular carcinoma in situ is not in itself considered malignant but arise at 30% of the risk for breast cancer. HRT during menopause, ionizing radiation, and lack of physical exercise. Signs of the breast cancer may include lump in the breast, often without pain, change in breast shape, dimpling of the skin, milk rejection, a sign in which an infant rejects a nursing mother milk from a particular breast. It is a marker for a possible breast cancer. And fluid coming from the nipple, nearly inverted nipple, a red peeling flaky skin of the breast, and in those with distant spread of the cancer there may be bone pain, swollen lymph nodes, and shortness of breath. Breast can be divided according to the percentage-wise occurrence of cancers, such as superior lateral 50%, superior medial 15%, inferior lateral 11%, and inferior medial 6%. Breast cancer can be categorized according to staging system such as stage 0, that is limited to DCIS, stage 1, that is small cancer less than 2 centimeters in diameter, there is no axillary or distant disease, stage 2, that is large cancer, the cancer can range from 2 to 5 centimeters in diameter or there is axillary node involvement. Stage 3, that is extensive, local and regional spread is there. Cancers are greater than 5 centimeters or cancers with lymph nodes fixed together in a matted axillary mass. And in stage 4, that is distant metastasis. Metastatic spread is toward the axillary lymph nodes, bones, lungs, liver, opposite breast, and skin. Axillary lymph nodes can be divided into three levels. Level 1, that is low axilla. Level 2, more medial under pectoris minor. Level 3, most medial under clavicle. Positive supraclavicular and internal memory nodes are considered distant metastasis. All palpable lesions should be referred for a mammogram in appropriately aged women. Screening has led to a nearly 30% reduction in mortality compared with unscreened group. Mammography is the primarily a screening, not a diagnostic tool. Mammography is the most sensitive study for detection of small lesions. Mammographic imaging is being done yearly on a woman of 40 years of age with family history, and for women of age 50 years have no family history. Mediolateral view and the craniocaudal view are the standard screening views, whereas additional views are used for the diagnostic evaluation like as exaggerated craniocaudal view, lateral views such as mediolateral and lateromedial views, axillary tail view, cleavage valley view, spot compression view, magnification view, tangential view, and roll views. The ACR Breast Imaging Reporting and Data System by RATES Atlas provides a lexicon to standardize the breast imaging reporting and management recommendations. So 0 denotes needs additional mammographic evaluation or previous mammographic for comparison. 1, that is negative, means return to annual screening. 2 is equal benign, characteristically benign lesion. 3 denotes probably benign, that is less than 2% of malignancy, non-calcified, circumscribed, solid lesion. 4, that is suspicious, likelihood of malignancy that is greater than 2% up to 95%, and biopsy is recommended. 5 denotes highly suggestive of malignancy that is greater than 95%, and biopsy is very recommended. 6 denotes the biopsy proven malignancy. 99% of all the malignant breast tumors are epithelioid tumors, that is adenocarcinomas, that have their origin in the terminal duct lobular unit. Of these, 90 are ductal and 10% are the lobular in origin. The tumors of ductal epithelium in origin comprising carcinoma in situ, that is DCIS, and invasive carcinoma comprising of medullary carcinoma, mucinous or colloid carcinoma, papillary carcinoma, tubular carcinoma, inflammatory carcinoma, and Paget disease. And tumors of lobular origin are like is lobular neoplasia, invasive lobular carcinoma. The tumors of stromal origin are like sarcomas, fibrosarcoma, liposarcoma, lymphoma, and rare tumors are like phyllodes and carcinosarcomas. Metastases to the breast are like melanoma, the most common, and lymphoma. Here I will discuss the two most common occurring breast cancers, such as invasive ductal breast cancer, that is comprising 80% of the occurrence, and the invasive lobular carcinoma, that is 5 to 15% occurring. Invasive ductal carcinoma of no special type, not otherwise specified, is the most common form of breast cancer, comprising 80% occurrence. The abnormal cells that originated into the linings of the breast milk ducts have invaded surrounding the tissue over the time, can spread to the lymph nodes and possibly to other areas of the body. Infiltration of the tumor occurs into the dermal lymphatics, which leads to the inflammation and skin thickening. Invasive ductal carcinoma typically measures about 2 centimeters at the diagnosis time, with calcifications, and microscopically the extensive collagen occurrence. X-ray. This test is performed for checking of the spreading of the breast cancer to the lungs. In this chest X-ray of a woman with breast cancer, here we can see the multiple nodules of variable sizes throughout the lungs, suggestive of pulmonary metastasis. Mammography in case of invasive ductal carcinoma measures irregular mass with or without calcifications, speculated and hyperdense, circumscribed, clustered or amorphous or pleomorphic microcalcifications. In these mammographic views, in craniocaudal view and medial lateral oblique view of a case of Biarritz foie, here you can see the mass with irregular and speculated margin and internal microcalcification at the upper central portion of the breast. Ultrasonography in case of ductal carcinoma can show ill-defined hyperechoic mass, hyperechoic angular margins, posterior acoustic shading 71% in grade 1, and posterior enhancement 45% in grade 3. Branched or speculated pattern, and on Doppler shows increased vascularity. In this ultrasonographic image, here you can see a speculated, ill-defined hyperechoic mass lesion, taller than wide, with angular margins and infiltration of the breast parenchyma. Few echogenic foci of calcifications are noted. Invasive lobular carcinoma. It is the second most common form of invasive breast cancer, accounting for 5 to 15% of the breast cancers. Invasive lobular carcinoma starts in the milk-producing glands called lobules and can spread to the other parts of the body. On mammography, the findings of invasive lobular carcinoma are often subtle as there is no microcalcification. On mammography, they appear speculated masses, and these tumors are often isodense to the fibroglandular tissue. In these mammographs of a woman with breast cancer, here you can see in both views, craniocaudal view and mediolateral oblique view. However, invasive lobular carcinoma are often being better visualized on craniocaudal view than the mediolateral oblique view. In this view, here you can see a mass in the upper outer quadrant with irregular speculated margin and maximum diameter of 3.6 cm, which was shown to be a multifocal invasive lobular carcinoma. Invasive lobular carcinoma on ultrasonograph, 60% lesions exhibit typical features of malignancy and present is hypoechoic heterogeneous mass with ill-defined margins and posterior acoustic shadowing. Internal hypoechoic patterns are more marked, commonly seen. In these four different ultrasonographic images of invasive lobular carcinoma, here you can see hypoechoic, irregular, speculated lesions with posterior acoustic shadowing. The tumor in the image was almost isoechoic to normal fibroglandular breast tissue, but shows multiple pathological Doppler signals due to extensive neovascularization. Please subscribe my channel for more videos and updates.